Good evening, everyone. I think we're going to go ahead and get started so we can keep on schedule. My name's Christy Hawley. I'm a medical student here at GW. I'm also the president of the Benjamin Rush chapter here. I really appreciate all of you coming. I know the weather's been pretty nasty, but I'm glad that you could all be here. I know we have a lot of busy medical students and clinicians, so we really appreciate you taking the time out to have this really interesting debate with a great line of speakers. I also just wanted to introduce Beth Haynes. She is the executive director of the Benjamin Rush Institute, and she's here all the way from California. So I thought she would do probably a better job of explaining the organization than I would. So if Beth could come up and give us some information.
I want to make this short because I really want to hear what these guys have to say. I don't know about you, but Benjamin Rush has been around for 5 years. I've been with it for 2. Prior to that, I did 20 years of emergency medicine and several years of health policy analysis, which I did on a volunteer basis. So this is really fun. The purpose of Benjamin Rush is to try and broaden the conversation that we're having in our academic centers about healthcare policy, medical ethics, and in particular, making sure that the doctor-patient relationship is foremost in any discussion we have about what we're going to do about healthcare policy. We definitely have a free market orientation in our philosophy and our backgrounds, but I think the most important thing we can do is bring people together, the best speakers for each side. That's what's so exciting about debates. And medical students are medical students and not law students for a reason. We tend to want to have everybody get along and make everything better, and we can shy away from controversy. But if you've ever played sports, you'll know the best games you had were against the teams that pushed you the hardest. And that's the way we're going to get the best thinking. Not so much in the political field because it turns into sound bites and they have to win elections, but within us as physicians, trying to come together, find a way to dialogue in a method that's going to move us forward. But to do that, we have to really clarify the positions. And that's where debates come in. So thanks for coming. And I hope you will consider checking out BenjaminRushInstitute.org on the website. And if you like what we're doing, support us. Even if you don't agree with our ideas, if you like the format and what we're doing, please do support us. Thank you.
Hi everyone, my name is Annie Allen. I'm a second-year medical student here at GW, and I am the vice president of the GW chapter of the Benjamin Rush Institute. If you're interested in joining, if you are a GW student or a faculty member, you can feel free to find myself or Christy at the end of the debate or anytime afterwards so that you can get some information from us, or you can just follow us from our emails. Also, the debate tonight is going to be tweeted. So if you have any questions for the speakers and you don't want to go up to the microphone during the audience portion, you can write your questions at hashtag BRI-GWU, and maybe your question will be used. We're not going to use all of them, obviously, but hopefully, you know, if you're a little shy, we can try that. And also you can follow us at handle at BRI_GWU for our specific chapter. All right, so I just want to start off introducing our moderator, Dr. Charles Macri. If you're a medical student here, you know him well. Dr. Macri is director of the Division of Maternal Fetal Medicine and of the Student Education of Obstetrics and Gynecology at the GWU MFA, as well as professor of obstetrics and gynecology at the George Washington University School of Medicine and Health Sciences. Dr. Macri's board certifications include obstetrics and gynecology, maternal fetal medicine, and medical genetics. Dr. Macri completed his medical education at the Medical College of Virginia, residency at the Naval Hospital in San Diego, and his fellowships at USC LA County Hospital and Children's Hospital of LA. Dr. Macri is an extremely valued mentor among the George Washington University medical students, which is evidenced by his consistent student-voted Golden Apple Awards, his School of Medicine and Health Sciences Distinguished Teacher Award, and the Leonard Tao Humanism in Medicine Award presented by the Arnold P. Gold Foundation. We are extremely grateful to have Dr. Macri here with us today as our moderator. So thank you, Dr. Macri.
Thank you, and thank you for that very nice introduction. I appreciate it. And post-call, so I'll try to keep on target here. For arguing for the affirmative tonight is Dr. Scott Gottlieb. He's a practicing physician and has been a resident fellow at the American Enterprise Institute since 2003. James C. Capretta is a senior fellow at the Ethics and Public Policy Center, EPPC, and a visiting fellow at the American Enterprise Institute. Arguing the opposition, Sara Rosenbaum, JD, is the Harold and Jane Hirsh Professor of Health Law and Policy and founding chair of the Department of Health Policy at the George Washington University School of Public Health and Health Services. Dr. Seth Trueger, MD, is a health policy fellow in the Department of Emergency Medicine at the George Washington University. At this point, we'll start off with the first speaker for the proposition, and you will have 5 minutes.
Thanks a lot for the introduction. I appreciate the opportunity to be here tonight. I want to start with a concept I think most of us would agree on, that as a nation and as a government, we need to make it part of our mission to try to provide affordable, quality health coverage to all Americans. And the President deserves a lot of credit for forcing a reckoning on this point. It's a point that many have ascribed to over the years, but has eluded us for a very long time, and the debate is finally here. And our debate partner tonight, Sara Rosenbaum, also deserves a great deal of credit. She's worked on this ideal for a very long time, making a lot of progress along the way. But having thrust this issue to the center of our political debate, the bottom line is this: Obamacare will not fulfill its own noble ambition. And it's not just a matter of tinkering with the program to fix its obvious shortcomings. The entire structure, from our view, is fatally flawed, and it needs to be replaced. My colleague tonight, Jim Capretta, will talk in greater detail about what that replacement plan would look like. I want to briefly lay out just several of the reasons why we believe Obamacare is beyond resuscitation, and I'm sure we're going to get into more detail as we debate this point tonight. No amount of intensive therapy, in our view, is going to heal its wounds. The law is based on 2 simple ideas, if I was to boil it down from a 10,000-foot level. The first is that it's necessary to federalize the entire market for insurance coverage in order to regulate it better and ultimately subsidize access to those insurance products. And then, having wrested control of coverage from the states, the law uses that leverage as a way to standardize coverage to make sure everyone gets about the same thing. And this isn't out of just some principle of egalitarianism, although it's partly out of that. It's also a necessary part of the standardization of medical care and health coverage that Obamacare's architects believe is required in order to make the scheme work. In other words, the only way to provide a uniform set of subsidies for buying coverage for individuals is to make sure that all the health plans are pretty much the same. And that's how you know that the price of the subsidies are appropriate for what you're buying. It sounds simple enough, but the problem with the scheme is that it never really ends. Healthcare is inherently a local endeavor. The attempt to try to federalize its provision and payment across a very diverse demographic and in a very diverse country with many different kinds of provider arrangements leads to all kinds of distortions. First, in mandating a very prescriptive set of health benefits and leaving people with little choice when it comes to their coverage, Obamacare's architects basically squelch the kind of competition that leads to price competition in the marketplace and help keeps costs in check. And the result is that the Obamacare plans ended up being very, very costly. And we'll get into the details on those costs a little later. The architects of Obamacare realized they had a cost problem, so they used other tools to try to control these prices. But these additional controls on the market and on medical care only created more distortions and more hardships for patients. First, they try to encourage health plans to offer very narrow networks of doctors as a way to let plans have leverage over providers to control what care gets delivered and ultimately control costs. They let plans bid by county level, which basically means many plans are only offering providers on a county-by-county basis. Second, they mandate different forms of capitation to put the financial onus on physicians to basically ration care. We basically traded one bad set of incentives where doctors were paid more to do more for another bad set of incentives where doctors are paid more to do less, a real throwback to the old HMO model. Third, the law encourages direct rationing and control of medical care and control of prices through commissions and boards, a whole myriad of new entities, groups like IPAB, and even the USPSTF, United States Preventative Services Task Force, which is being co-opted in this. So in short, a complex system like healthcare, with each intrusion into the market, it's going to require a corresponding set of additional controls just to deal with the unintended consequences of those first instances of regulation. And that's exactly what we are seeing unfold. The problem is with each new set of controls comes still more reverberations in the healthcare system and more unintended consequences. The entire law as a result is structurally unsound. It is, simply put, a house of cards. The dozens of regulatory tweaks and executive changes that the President himself has made and signed over the last several months is an anxious attempt to try to deal with these organizational flaws. But we believe they can't be dealt with because the underlying premise is in need of so much intensive care, and it should be sent to the morgue, fully repealed and then replaced. Thanks a lot.
Thank you very much for that emergency room approach to things. For the opposition, who will be speaking? Ms. Rosenbaum, you have 7 minutes.
Thank you very much. Well, first of all, happy second Seder for those of you who are celebrating Passover with us tonight. God is smiling on us that we are thinking deep thoughts on this holy day. And thank you also to the Institute and to the medical school for doing this and for the kind introduction. Dr. Gottlieb raises a lot of important issues, although these are the kinds of issues that one typically deals with when one is attempting, after passing landmark legislation, to go through what is the normal way we do things in the United States, which is a process of continual amendment and change in order to make a law work more properly. This was the story with Medicare, which has been amended hundreds and hundreds of times. There's the story with Medicaid, which, despite its own flaws, survives and in its 50th year as the greatest of all insurance programs in the United States, actually the biggest, and carrying the most responsibilities. It's been the story. It was the story with Medicare Part D, which was very much a prototype for the Affordable Care Act, a Republican law, to essentially cover all Medicare beneficiaries for prescription drugs through premium assistance. It was the story with the Children's Health Insurance Program, again, a prototype for the Affordable Care Act in the sense of giving, in this case, families premium assistance to buy affordable insurance for their children. Each time we have established a program, and then everybody's gone to work on trying to make it work better. I think it's important to remember that this is a country of evolution in its laws, which is one of the things that makes us such a great nation, actually. And to go back to sort of first principles in thinking about where the Affordable Care Act gets us, the sort of the Rubicons that we have crossed here that we simply now as a nation cannot go back on. So nobody wants to return to a time when illness or having a health condition meant being shut out of affordable insurance or out of any insurance at all at any price. And if we don't want to go back to that time, then obviously we have to do something to create the stable economic environment that allows us to have an insurance system. You can do it in a number of ways. The Affordable Care Act does it by reforming the insurance market in a number of ways. Leaving it very much, here's a point of disagreement with Dr. Gottlieb, as a state-regulated insurance market subject to certain federal requirements, one of them being, of course, the pre-existing condition exclusion ban. So we don't want to go backwards, which means working on the landmark pre-existing condition exclusion ban that now exists in law and improving the way it operates. Nobody wants to go back to a time when free riders were a standard. We have made remarkable progress, even in 6 bumpy months, toward getting people insured, and we really don't, as a nation, want to tolerate a time again when the rest of us were called upon to pay for health care furnished to 50 million people, often too little, too late, in inappropriate settings. And certainly nobody wants to go back to a time, although the Supreme Court has managed to set us back a little bit a lot, depending on your point of view. Nobody wants to go back to a time when only certain categories of poor people were able to get public insurance, when most working poor people were left out of Medicaid program, which became a staple of the act in order to take some of the pressure off the risk pool. We have not seen a big, bold alternative to the Affordable Care Act at this point for a reason. Because the Affordable Care Act, much to the chagrin of some of us who were probably to the left of the main tenets of the act, the Affordable Care Act itself is the product of a very conservative set of ideas, namely that you leave a private insurance program in place. More than some would like, you leave employment-based coverage essentially alone. You build up an individual market. You make it possible for all people in the United States to get access to a market, which means some federal intervention in the market, but still fundamentally state-regulated insurance products. And you subsidize the market so that people who don't have employer coverage can get what I get as an employee of GW, which is a very well-subsidized insurance plan. These are very simple principles. They were the principles laid out, more or less, in a proposal made by the Heritage Foundation in the early 1990s. I worked on a similar proposal with Senator John Chafee in 1993 as the Health Security Act was going down the tubes. And while the course of reform has proven to be very difficult and will continue to be difficult for reasons we can get into, we see that 7.7 million people have gained insurance, which is an undercount because there has been off-exchange coverage as well. We've seen 3 million additional people enrolled in Medicaid. We've seen a nearly 3 percentage point gain in insurance between the third quarter of 2013 and the fourth quarter of 2014. With the most dramatic gains, I think this has maybe been the most heartening for lower income families. So the law is working the way it's supposed to work. It has helped people who can't afford coverage to gain coverage. Could there be improvements? Of course there could be improvements. This is the nature of big legislation. You put it into place and you revise it and allow it to evolve. And hopefully we will follow the same pathway here that we did in the case of Medicare Part D, the case of CHIP, and continue as a nation to grapple with reform.
Thank you, Ms. Rosenbaum. And now the second speaker for the proposition. You have 7 minutes.
Thank you. I'd like to make 3 broad points about the state of this discussion. First, it's important to realize that what really divides the sides in healthcare is the answer to the following question, which is, how can we bring about more efficiency in the healthcare system? Now, whenever I say this to folks, they often will say, well, that seems like kind of a side issue. Really, isn't this about coverage, et cetera? Well, actually not. Because without a more efficient healthcare system, which is really at the core of what people are trying to get at, to control costs in the system, you have to put a cap on the system, and if you aren't making it more efficient, then quality will go down. There will be some element of rationing or reduced quality to try to bring costs under control if the system doesn't become more productive. So how do we bring that about is sort of one of the key questions. And so much of what passed in the 2010 law was about making the federal government really central to that equation, both not on the insurance side as well as the delivery side, how physicians and hospitals organize and do their business. If you look at the law, it's got scores and scores and scores of provisions related to control over both aspects of this. So when people ask me what really is the animating principle of the 2010 healthcare law, I always tell them it's really to move authority over many aspects of the health system from various parties and actors to the federal government. The opponents of the healthcare law really view this as a long-term threat to the quality of American medicine. That is, to the extent that the federal government does essentially becomes sitting in the driver's seat of American healthcare, both on insurance regulation as well as the delivery side, that will diminish the quality of care over time for a variety of reasons that are just part of the politics of governing a health system. For those who don't think this is really a central issue, I would take you back to the 2008 debate between then Senator Obama and Senator McCain over health care reform, you might recall that Senator McCain proposed what was essentially a universal coverage plan. Universal tax credits for everybody in the country below the age of 65 that would be uniform for everybody. Very, very progressive, by the way, compared to the current structure. More progressive, candidly, than the president's proposals. It was attacked very, very vigorously by then Senator Obama because it would have moved much more heavily toward a market-based system without as much federal control over the structure. Similarly, when Congressman Paul Ryan proposed a market-based reform of the broader Medicare program, it was attacked very, very heavily by opponents because it would move control out of the federal government over the Medicare system. So really at issue in these debates is federal control versus a more decentralized market-driven system. That is the key question. My second point is that the law cannot be fixed because this animating principle of federal control over the system is infused in every nook and cranny in the law. It's all over the place. If you just go through it, there are literally hundreds of instances of the Secretary of HHS shall do X, Y, and Z to govern the system. Among the things that are now under full federal control are what is to be included in every benefit package. So far, they've deferred somewhat to the states, but they don't have to. The federal government has the complete authority in the law to define what's in everybody's insurance package nationwide and essentially outlaw the ability to get anything differently. Full control over which insurers can be participating in the exchanges. If the federal government decides that some insurers are not playing ball in terms of keeping premiums under control, they can exclude them. So they've got total control essentially now over the marketplace. And a number of other things, including IPAB and the Innovation Center. The third thing I want to point out here is that there are alternatives to the 2010 law. We did not have to pass the 2010 law to broaden insurance coverage and improve the cost equation in American healthcare. There are definitely alternatives to this. I would just go through one, which is Senators Burr, Coburn, and Hatch have proposed an alternative plan. It includes essentially the following elements. One is that people who stay continuously insured would never be charged more based on their health condition when they switch insurance coverage. So that means if they go from the employer-based system to the individual market and they've been continuously insured or close to continuously insured, they can do so without losing their status as being protected from getting charged higher premiums based on that. Retention of the employer-based system without major disruption to it. Unlike the current law, we don't need to disrupt the employer-based system. It was basically working pretty well prior to the enactment of the 2010 law. Costs are going up dramatically in that system now because of the 2010 law. I think it should be basically left alone and with some additional cost discipline, that is the tax preference for employer-based coverage should be limited at an upper level, but a pretty high level, but basically left alone. And then much more flexible tax credits for coverage outside the employer system. There is some common ground there with the 2010 law, but the tax credits do not have to be nearly as, first of all, expensive as the ones that were passed in 2010, and secondly, as inflexible as the ones that were passed in 2010. Fourth, state flexibility. Allow the states actually to decide how and where they want people to access their insurance coverage. They don't have to build uniform, federally required exchanges to do that. And then fifth, Medicaid reform. Allow people on Medicaid to get the same mainstream insurance plans that are offered to people outside the employer system. This is an important change. Right now, people on Medicaid, this is the non-elderly, the non-disabled, people that are using Medicaid essentially for health insurance, oftentimes when they have a life change situation, they get a better paying job or they switch employment or their family situation changes, they can actually lose their Medicaid, and then they end up getting disrupted in the kind of care that they have. They should be in the same mainstream insurance plans that are offered to other people through the tax credit system. So if you adopt this kind of approach, you could cover as many people as the healthcare law could. You could do it at a fraction of the cost, at a fraction of the bureaucracy, and certainly at a fraction of the financial exposure to the federal budget over both the near term and the long term. Thank you.
Thank you very much. The second speaker for the opposition You have 7 minutes.
Great, thank you very much, and want to thank you all for coming, and thank you for inviting me to speak here. I'm very flattered and humbled to be on this very esteemed panel. I think what I can start with is talking about the Coburn-Burr-Hatch bill. And I think what that bill really showed is, or that plan, excuse me, it's not really a bill, is that it shows two things about the state of health reform in this country. One is that there is pretty much an irrational political obstructionism in Congress to basically anything that has to do with the Affordable Care Act, which really makes the bill pretty much, or the plan, a non-starter for the Democrats in the House, the Senate, and the White House right now. The first Title I of the Coburn-Burr-Hatch plan was simply to repeal Obamacare with a small asterisk to keep all the cost savings that happened that Obamacare did with Medicare. And the second thing is that it really illustrates is that pretty much any market-based health reform, the more and more fleshed out it becomes as a plan, it becomes more and more like the Affordable Care Act. Basically, you need, the Affordable Care Act gets criticized quite a bit for its kind of Rube Goldberg-like construction, all these different moving parts, but that's really just necessary. It's mandated by the complexity of trying to maintain the private for-profit insurance market for health coverage in this country. One of the major problems with the Coburn-Burr-Hatch plan is that instead it gets to the guaranteed issue, the end of pre-existing condition exclusions through, and it stopped the gaming from that process, with instead of an individual mandate, it uses this continuous coverage provision. The problem is that in order for the continuous coverage provision to not really be detrimental for the lower middle class, is there has to be really affordable plans, and there need to be robust subsidies to make sure that when somebody loses their job, it still has enough assets or income so they don't qualify for Medicaid, that they can afford a plan. The subsidies under the Coburn plan are actually much lower than the Affordable Care Act plans, and a lot of people wouldn't be able to afford insurance on the market and would lose these pre-existing coverage protections, pre-existing condition protections. I think there's certainly some areas we can talk about. I disagree with the characterization of the Affordable Care Act as a federalization of health regulation. I think it certainly sets a federal floor for health regulation, but it does not mean that everybody gets the same coverage. It means that everybody gets the same minimum coverage, that plans have to have some sort of inherent value. One of the big problems with the individual market for health insurance before Obamacare was that there were plans with very big premiums where people were paying premiums out of proportion to the coverage they got in the plan. The plans had all sorts of complexity, which was misleading, confusing, and people couldn't really understand. When I was in residency, I lost my parents' coverage. No, sorry, in med school, I had to get my own plan, and I was paying something like $60 a month, which wasn't very much, and got basically no coverage whatsoever if I got sick. Now, every plan on the market, yes, the premiums have increased for some people on the individual market. But what that means is that those plans have essential health benefits, so that if you get sick and need to go to the emergency department, if you need hospital services, if you need mental health coverage, you actually get those services because your plan covers it. Additionally, the Affordable Care Act adds other consumer protections, like the end of annual and lifetime limits to benefits. Back in September, I think it was, Home Depot made some news because they dropped their health insurance coverage for their part-time workers. And it was actually funny when you look at the details of the plan, it wasn't really health insurance coverage. The plan capped at $20,000 worth of benefits. And if any of you have ever gotten a bill from the ER, you know that I can order, sitting on a shift, I can order $20,000 worth of tests without getting up out of my chair. It's very, very easy to do with the prices that we have. Which really gets to one of the other major criticisms of the Affordable Care Act, which is the narrow networks. Now, I don't think anybody who is a proponent of the Affordable Care Act or who really wants this sort of approach would say that we want there to be narrow networks. I think there's something that happened for a couple of reasons, but I don't think they're inherently bad. The main interaction in the healthcare market at this point is the interaction between the payers and the providers. That's what determines prices. And the way that the payers, the insurance companies, have leverage is they can decide which providers are inside their network, and that's how they can negotiate a price. Pretty much the only way at this point that we can bring down prices without true federalization, something like price caps or reference pricing, really the only way that the tool we have right now without some sort of overarching regulation is through the private insurance companies using some sort of narrow networks. Basically, the insurance companies say, we're only going to pay you so much, but we'll guarantee that all our patients will be able to go to you because they'll have coverage. And, it's unfortunate that a lot of some of the top hospitals and other providers in the country are left out of some of the less expensive plans, but really they were just simply too expensive. And this savings by keeping the networks narrow is passed down to the enrollees in the plans through lower premiums, and is passed down to all of us in the terms of lower healthcare expenditures in the long term. I would say that one of the areas that I think most of us could agree on would need some improvement is the narrow networks. I think, again, the Affordable Care Act isn't a story of the federalization of healthcare regulation, but in some ways it's the states punting their oversight duties to the feds. One of the problems that we saw in a lot of states is that the state insurance regulators gave Medicare through CSIO the power to regulate or enforce the narrow network or the network adequacy requirements. This stuff is always a mouthful. And CSIO basically didn't do a very good job of it and punted it back to the states. The states again did a bad job of it, and you end up with a lot of places where, like New Hampshire, for instance, where there's essentially at this point one plan in the marketplace, or excuse me, one provider of plans in the marketplace, and they have a pretty small network and probably smaller than it ideally would be. But I think this is, again, isn't because the federal government made them have a small network or anybody wanted a small network. It's because both the states and CSIO, to be honest, abdicated their responsibility. And something that we've seen in the data now is that there's a consumer preference at this point for narrow networks. This is in the 1990s. This isn't when the major option for narrow networks was HMOs and you had one tier of providers. Right now, basically we've seen now that most of the narrow networks are through PPOs, where there's a tier of providers with different amounts of cost sharing and different pricing. Additionally, I think that the difference between consumer preference from 20 years ago is that premiums have just gone up. And they went up long before Obamacare started. And this is another one, probably the best point to close on, is that the biggest criticisms of Obamacare, higher premiums, narrow networks, increasing deductibles, these aren't things that started suddenly in 2010 or 2014, but these are continuations of long-term trends. It's going to take a number of years to see whether or not, what happens, what impact Obamacare has on premiums, on deductibles, on network wideness over time. I'm optimistic at this point. I think right now the amount of people we're getting into the insurance market is really going to be better for everybody, and I look forward to talking about this more.
Thank you, Dr. Trueger. We now have rebuttals, and it will be in the same order that you spoke, and you'll get 2 minutes each.
Well, I would just argue the point that if it's so good, why isn't anyone showing up? If you look at the numbers that the CBO put out as recently as yesterday, the Congressional Budget Office, and I'm not really sure that these numbers really tell the whole story. I think they were understating some of the migration you're going to see, particularly from the employer market into Obamacare. They anticipate that by 2024, there'll be about 25 million people in the Obamacare exchanges, and about 12 million people, if I remember correctly, will lose their employer-sponsored health coverage as it gets canceled. I think that's probably a low number, but let's just accept their numbers. That means there'll be 13 million people net on private coverage as a result of the Affordable Care Act. The balance of the uninsured who gain insurance will be put on Medicaid, which I think is another program that we did very little to fix that has a lot of systemic problems. So we effectively spent $1.8 trillion to insure about 13 million people on private coverage. We quite literally could have bought them all a Bentley and a gold-plated health plan and probably would have saved money. The problem is that the plans themselves, and it gets back to the point Jim made about the successive layers of government control. What you end up with is a plan that is so expensive and so tightly regulated that it becomes not only unaffordable, but unattractive for the average consumer. And so to give you some prices, a 30-year-old who earns $30,000 annually, which is the average price for average salary for a school teacher, an average silver plan. Now, an average plan will cost $2,700 and still have a $5,000 deductible. That's not an attractive plan for a consumer because these plans were designed in Washington and weren't designed in the marketplace where people actually make decisions about what they want. And that gets to the issue of wresting control away from the states, away from health plans to have discretion to design things for consumers and things that consumers are going to want in the marketplace. And that's why you don't see people signing up. And these aren't just issues that can be resolved through tweaking the law. These are systemic issues. This is how the law was designed. There's multiple layers of controls on these plans. And the only way to really design something that's attractive in the marketplace is to give control back to the states. And that's going to take a whole different kind of scheme.
Thank you, Dr. Gottlieb. And now arguing the opposition.
So what to do with my 2 minutes? I think I'm going to just take one item from the list that has come up now several times. Federalization of coverage design, meaning sort of this image of essential health benefits being this highly federal regulatory structure that has essentially stultified the market, wrested control from the states. So let's just take a look at that. Because I think in this one example, you begin to appreciate that we're really at a point of modifying the Affordable Care Act, not having to wipe it off the books because it's an insufferable invasion of liberty. So essential health benefits are based on the notion, and this is in the statute, that any qualified health plan, as they're called, that's sold in the market, so whether it's sold in an exchange or it's sold in the individual or small group market, should cover 10 classes of services. Doesn't say how much of any service or the design of any service. It has to cover some hospital care, some maternity care, some well child care, some preventive care, some rehab services, some mental health and substance use disorder services, something called medical care. Interestingly, there's a category called, or a subcategory called habilitation, which is new, not typically done. The 10 categories of essential health benefits, you might wonder where they come from. They come from what is the typical, and that's literally the word in the statute, the typical employer plan, meaning state-regulated employer group insurance plan. So what Congress did was to direct the Secretaries of Labor and HHS to find out what the typical state-regulated employer insurance product was and literally follow it. So the irony here is that the federal standard of what's an essential health benefit is virtually a parroting of what is the amalgamation of 50 states' typical state-regulated employer plans. It lists the same 10 benefits except for habilitation, which is a little unusual, that you would find in any state's insurance market, and leaves coloring in the details to insurers.
Thank you, Ms. Rosenbaum and Mr. Carpretta, sorry.
Just a few points in rebuttal. One, the Burr-Coburn-Hatch plan would not leave people with unaffordable premiums. Actually, the credits that they would provide would be sufficient to buy at least catastrophic insurance coverage for everybody. So there would be no reason why everybody in the United States wouldn't have continuous coverage. You can always raise a deductible a little bit more and make it equivalent to the premium equivalent to the credit. So yes, people might be in higher deductible plans, but everybody, including moderate income people, would have at least catastrophic insurance coverage, which is really the point of having financial protection in healthcare. Second thing is, the Burr-Coburn-Hatch plan is nowhere near looks like the 2010 law. If you doubt that, just ask the people that passed the 2010 law if they'd be willing to trade it for the Burr-Coburn-Hatch plan. It wipes away huge amounts of federalized authority in the health system and makes it a decentralized, much more market-driven, flexible system that can adapt for a very big and diverse country. Honestly, there's so much that goes on in that law, which is, we're only at 2014. You got to think of the political economy of this law over a 10 and 20-year period. It's opened up huge avenues of authority for the federal government. Yes, this is how they've handled essential health benefits right now, but that's not necessarily how they're going to handle it 10 years from now. They can always add more requirements, especially through the regulatory process. We've seen through the regulatory process how open-ended it is. They can do much more. So just because here's where we are now, which is already pretty onerous from the perspective of a lot of people, they can add a lot more regulatory requirements as time goes on. I think the other thing to realize here is that the part of the issue is the birthing of the bill itself, right? It was a very politicized process, and it passed under the most partisan of circumstances, And quite candidly, the administration really hasn't wanted to move off of the direction where they are. And so the idea that this is going to be easily resolved, I think, with just minor tweaking, I think is really a fantasy.
So we've heard this discussion. Oh, pardon me? I was ready to stop it now. I like that last, oh, sorry.
No, no problem. I'll try to keep it to my 2 minutes. So I think Dr. Gottlieb made a couple great points. I think that the first one is that where are all the people who are signing up? First of all, we know there's 7.7 million people who signed up through the exchanges. We know there's more who bought health plans outside of the exchanges. We know there's more people who are going to continue buying it through the year as they get, they change jobs, they have kids and things like that. So this is actually pretty good for the first year. Nobody expected it to be, to suddenly fix uninsurance in 1 year. Compared that to the Paul Ryan plan, which was released a few weeks ago, I believe it was the Committee for Responsible Federal Budget estimated that 20 million fewer people would be insured under that plan. So if the goal is to get more people covered, then Mr. Ryan's plan, unfortunately, is not the way to do it. I think another point that was made is that the federalization of the regulation, which I don't know if I necessarily agree with that, like I said, it isn't the best way to do it. We need the state-based, the markets in the states and the regulators in the states to figure out what's best for their constituents. This is what we had for about a century, and the system that we had before the ACA did not do a very good job of that. People with pre-existing conditions were priced out of plans or excluded entirely from plans. People who didn't have pre-existing conditions were paying much, much more for plans than anybody thought they should for plans that didn't have much value at all. We tried a state-based system. The ACA is essentially a hybrid, I'd say conservatively, a hybrid state-federal system where the states have a lot of discretion. Was it 34 states decided not to do their own marketplaces? 25 states, I think, are still decided not to expand Medicaid. Some states are actually using the law are getting waivers to expand Medicaid in their own ways. For instance, the Arkansas plan, which we're going to have to change the name of because Arkansas is probably not going to do it anymore, where Medicaid does turn into a voucher system. And I think, again, one of the interesting points is that Paul Ryan and some others have advocated turning Medicare into a voucher-type plan where you can buy something on the market. We're essentially turning Medicare into the Affordable Care Act. But the Affordable Care Act apparently is not good enough for the rest of us.
Thank you, Dr. Trueger. So now you've heard the discussion. I have a couple of questions that I'd like to pose, and then I'd like to open it up to the audience. So for Ms. Rosenbaum and for Dr. Trueger, I always talk to the medical students, and when I'm interviewing people applying for GW, I write the number 17 trillion down in number format. And I ask them first, can they identify the number? And, I like to know that they know scientific notation. And then I try to get them to discuss what that means. And that happens to mean, the national debt. Is the Affordable Care Act sustainable? Is it going to add greatly to the national debt, and how will you deal with this?
I think that unlike a lot of alternative plans we've seen, the Affordable Care Act, at least for the first 10 years, and what we've continued to see, is that it's actually going to lower the debt. It brings down the debt. I think the last estimate was something on the order of $150 billion, which is lowering the debt. Healthcare costs are high. They're getting higher. We're trying to bend that cost curve down. I think the Affordable Care Act is going to do a lot more than a lot of other proposals. I think unfortunately, there's not a whole lot of ways to bring down medical costs without making tough decisions, but I think figuring out ways to bring the prices down, such as through narrow networks, is a really good way to do it. I think also taking the system we did before, if you think the Affordable Care Act is complex, what we did before to care for underinsured people were people who didn't have health insurance would not get adequate primary care, get care from people like me in emergency rooms where they were sicker and it was more expensive, and then we would all kind of shuffle around a whole bunch of money through things like dish payments and through higher premiums and higher healthcare costs for everybody else to pay for people who didn't have coverage. So figuring out a way to get everybody into the system, or maybe not everybody, but more people into the system, I think is a much better way to give us a lever on those out-of-control costs.
Thank you. And for Dr. Gottlieb and Mr. Capretta, do you think that the Affordable Care Act is going to impact recruitment into medical school for people in the future?
Well, I think people going into medical school have to have a different set of expectations. I think the Affordable Care Act and a lot of the reforms in the Affordable Care Act on the provider side, and a lot of these were Medicare-related reforms, really envision a world where doctors are going to be consolidated into entities where they're salaried employees. And the reason why it envisions that is, one, there's sort of this magical view that if you consolidate physicians, particularly around hospitals, you're going to get investments in the kinds of things that lead to better integration and coordination and delivery of care. And I don't think that that's necessarily true, because a lot of the things that have led to better coordination care are things that have come out of entrepreneurs. But nonetheless, it envisions this world where doctors are going to be consolidated and basically salaried employees. And so I think people going into medical school need to have that expectation. If this law persists and these reforms of the medical marketplace persist, I think people have to have the expectation that the idea that they're going to be practicing in a physician-led group with 10 or 15 physicians is gone. And they're going to be basically salaried employees of a very large entity, particularly hospitals. They're going to be punching in and punching out. Now, the biggest problem with that, from my standpoint, is that this has been looked at a lot in terms of what impact this has on the delivery of care. And what we've seen is that the productivity of physicians declines as they enter into these relationships. And if you believe, and Jim's made this point, that the only way to solve our long-term fiscal challenges with healthcare is to get more healthcare for every dollar of GDP that we spend on it, then the last thing we want to do is be reducing the productivity of the provider space. But that's precisely what we've done. Now, will people no longer go into medicine? No, but I think a different kind of people will go into medicine, people who embrace the concept that they will be salaried employees, and the ones who wanted to choose a profession where there was autonomy, lifelong learning, and a sense of entrepreneurship and ownership, they might find medicine less attractive.
Thank you. And now we'll have questions from the audience. There's a microphone there, and if people want to step up and... All right. Yes, sir.
Dr. Gottlieb, my name is Dr. Berlin, and health policy. I read your op-eds on a regular basis, and I enjoy them. Can you comment a little bit about price transparency? How do you think, going forward, that will actually affect efficiencies and costs? And do you think that would be the single biggest driver in terms of the Affordable Care Act, reducing costs and efficiencies, if we truly got consumers on board pushing price transparency?
I'm not really sure what the Affordable Care Act did to improve price transparency. I mean, there's been some regulations where Medicare pricing data has been released, although I'm not sure how informative that is to consumers. I think the most interesting things happening with respect to price transparency are happening in the private market with companies like WellTalk and Castlight, which recently went public, which are making information about prices much more available to consumers and allowing consumers to make decisions based on things like quality and price, which is what you need in to have a competitive market. I think in a world where more people are going to be in high deductible plans, and the Affordable Care Act, they're not truly high deductible plans, although they have very high deductibles. They're not structured like a traditional high deductible plan, because the concept of a high deductible plan is you have a high deductible, but things are paid for after, and this provides a lot of full dollar coverage for routine things, oddly chosen routine things mandated by the government through things like the USPSTF. But to the extent that consumers are going to be exposed to more costs because of the high deductibles, I think you're going to need to have more information available to consumers at the point of care to make those decisions. I don't know what the Affordable Care Act did to make that possible, though. I don't think there's anything in the law that improves transparency. There isn't. I mean, everything that's happening that's useful is happening in the private market.
Yes, ma'am.
My name is Carrie Treacle. I'm a practicing hand surgeon from Virginia Beach, so I'm not a healthcare policy wonk. I don't have any additional training, but I do have some interest in this as a compassionate surgeon. This is actually a question, this is a series of questions for all four of y'all. Why don't we see more conversations about divorcing health insurance from employment? And why don't we see more conversations about allowing insurance to be purchased across state lines? Is it because employers and insurance companies are powerful lobbyists for their own interests? That wouldn't these changes create a more market-based industry? And is the ACA designed to fail? Thank you.
Sure. Well, actually, a number of proposals have suggested separating health insurance from employment. This is something that Jim Capretta and Scott Gottlieb were both talking about. And you know, it's interesting from the right you hear solutions to divorce, and from the left you do as well, because of course the left would move toward a model in which everybody is simply covered through a universal single insurer, like Canada, for example. So both models, both ideals, sort of recognize that we made a big mistake. In retrospect, hindsight is always very good. We made a big mistake, 75 years ago when we started down an employee benefits pathway for health insurance. The problem is how to get out of it. If you look at the Affordable Care Act, I always tell my students, it reminds me, this is actually very appropriate for Passover. So Moses was given the 40-day route and the 40-year route, right? He was told you can get everybody to the promised land in 40 days, or you can take 40 years and wander around the desert. And he took the 40-year route because he wanted the old generation to die off. If you look at the Affordable Care Act basically leaves the employer-based system alone, as somebody already has mentioned. If you want to offer employment coverage, you can. If you don't, and you're a big employer, you pay a tax. If you're a small employer, you don't. The interesting thing is that the recent RAND study showed a big surge in employer coverage. More people picked up their employer's coverage than came in through the marketplace in the first 6 months because of the tax penalty issue. But over time, if you look for the past 30 years, you can see what kind of a downslope we are on. For children right now in the United States, fewer than half have access to a parent's plan for a lot of different reasons. But it had its zenith probably in the mid-'70s. It's been creeping downward ever since. You could view the Affordable Care Act as sort of a catch system, if employee benefits go away. So that's number one. I think it's kind of happening. It's happening as the nature of work changes, the nature of jobs change. My daughter, who's 35, will never have employer-sponsored benefits, probably. She's an independent worker. She has her own benefits. And I think she's pretty typical. As far as interstate sales go, this is something that's been talked about for a long time. And it's an interesting issue because it's precisely because we have a state-regulated insurance market that we don't have interstate sales. States have tried to get together on this, and a couple of states have experimented. They've put out a big sign that said, if you're licensed in any other state, you can come in and sell in our state. Georgia did this. They got no takers. Insurers did not want to come in and sell in Georgia. Georgia did this because it had a weak insurance market. So I think some of these things, they sound sort of good when you say them and you're sitting up here on a panel or you're talking on TV or, throwing out theories. But in the end, the insurance industry itself, it's going to take a lot of work before it divorces itself from its own state-based model. I'm sure we could think of incentives. The Affordable Care Act has multi-state plans so that you can get certified to sell in multiple states. But I'm not sure in the end that you'd get a whole lot of difference in the cost of medical care out of it.
If I can add one point to that, it's, like I said earlier, the key fundamental negotiation, the key act in the marketplace for health insurance is the providers and the insurance companies negotiating a network. If you are a provider in Atlanta, Georgia, or excuse me, a health insurance plan in Atlanta, Georgia, and you're trying to recruit a physician network in North Dakota for your patients in Georgia, it just doesn't make any sense. There's no way you can really negotiate good terms, a big extensive network. And I think the kind of other side of that is that, like Georgia was a state that had low regulations. We've all seen what happens when with banks and credit cards. Every bank and credit card is based in either Delaware or North Dakota because they have low regulations. We'd end up with probably instead of 6 big insurers, with 3 big insurers or 2 big insurers that were selling national plans out of Delaware, North Dakota, or similar states to that, without any protections for the consumers or the enrollees. Does anyone want Comcast selling them all health insurance?
One of the great ironies, there are many, many ironies of this debate, but one of the great ironies is that the large insurance companies, despite the president's rhetoric for the last 5 years, are essentially totally bought into the structure that passed in 2010 and are pouring huge amounts of lobbying money into protecting their interests as part of that, and actively working the regulatory structure to get their best interests protected as part of that. The whole thing has become the product of an alliance between President Obama and for-profit insurance companies, which is a huge irony here. And remember, there's an individual mandate now that it says everybody in America has to, or is supposed to, buy private health insurance, including from big, bad, shareholder-owned, for-profit insurance companies. And they're working the regulatory system and the political system to protect their incumbent status in a very big way. So to the extent that people think that this is some big populist thing that, it's going to look a lot like other things that have happened when the government gets involved. It'll be heavily influenced by politics and money and big business.
I think a lot of conservatives would say that the employer-sponsored system is suboptimal, that it's not the optimal place to be pooling to buy your coverage. And if we had real pools, even pools on a state-based level where people came together to buy coverage, you can have a more market-based system. I think what's going to happen, Sara referred to the employer, I think she implied that the employer-provided system is going to slowly die off as a result of Obamacare. I think that that's partially true, and it's more honest of a statement than you're going to get of anyone in the administration. I think that a component of the employer-provided system will persist, and this is what I believe will happen. Where you get your coverage in the future is going to be determined by where you get your subsidy. For a low-wage worker, someone who earns $30,000 or $40,000 a year for a family of 4, they're going to get their coverage in Obamacare. Even if they're getting their coverage at work right now, they're going to be pushed into Obamacare. If you're working for a company that has a lot of lower wage workers, people within that income range, maybe a little bit more, it's simply too good of a deal for those individuals to continue to provide them coverage at work, because the implicit subsidy they get at work from buying their coverage with pre-tax dollars is very small. They're in a low tax bracket, so they're not getting much of a subsidy at all. But if they go into Obamacare, if they're a family of 4 earning $40,000 a year, they can quite literally get a $12,000 subsidy to buy a $14,000 plan. That's huge. It's transformative. And that's why the unions are so worried, because they realize those industrial workers who fall within those income ranges are going to be pushed into Obamacare. It's better for the business, which puts its healthcare costs on the footing of that penalty, that $2,000 penalty that you have to pay per employee that you don't provide coverage for, which grows at the cost of the overall price index rather than medical inflation. And it's better for the worker. They're going to get much more of a subsidy in Obamacare. If you're a higher wage worker, mostly people who work for services companies, you're not going to qualify for any Obamacare subsidy, but the subsidy you get at work by being able to use pre-tax dollars is pretty good, because you're in a high tax bracket and your tax bracket's getting higher. So you get a pretty good subsidy at work. So you're going to continue to want your employer to offer you coverage at work so you can take advantage of that subsidy. So you're going to see a bifurcation in the market. Businesses that have a lot of lower wage employees, retail companies, industrial companies will be in Obamacare. And Zeke Emanuel recently came out and basically said as much. He expects most of the marketplace to shift into Obamacare. I think services companies that have a lot of higher wage workers will continue to offer coverage. The only question that remains is, will the plans be different? Now, the insurance companies publicly will say that the plans won't be different, that their plans that they offer in whatever persists of the employer-provided segment will be the same as the silver plans that they're offering in Obamacare. I think the plans will be very different, and I think you're already seeing insurers start to bifurcate with insurance companies like Aetna and Cigna moving more into their commercial segment, their shrinking commercial segment, and companies like WellPoint and Humana making bigger bets on Obamacare and the government lines of business. I think it simply will be the case that you cannot give a benefit to that commercial market and still make it cheap enough that to be commensurate with what you're giving in the government lines of business. The networks that you offer in those government plans are going to have to be very cheap networks to come in under that subsidy structure and under that regulatory scheme. And those networks simply will not be tenable in the commercial segment. So I think you're not only going to be seeing a tiering in the future among people who have Medicare and Medicaid and people with private coverage, you're going to see a much sharper tiering within private coverage itself between people who have commercial coverage and those who have been moved into Obamacare.
Questions from the tweet field? Yes, please. Speak up, though.
All right, so I'm not a clinician, I'm actually a student in the School of Public Health at GW, and I was wondering if the panel could discuss some of the quality improvement aspects of the ACA and how that goes to improve the deficit and also improve or not improve care into the future for patients.
Why don't I start? And the Affordable Care Act has a number of provisions that are sort of explicitly focused on quality. I would say, I mean, this to me has always been the joke of the American healthcare system, not quality, but the joke of the American healthcare system is that the easy part of the system is figuring out how to push the money around to finance things. Okay, that to me is the easy part. You've got several basic models for doing it. Would probably the spectrum of people up here represent several basic models for doing it. That part, every other wealthy country on the planet has figured out how to do. The hard part of health policy is dealing with the quality and efficiency of medical care because of the complexity of medical care, because of the uncertainties that exist in such large portions of medical care, because medical care takes such tremendous judgment. I mean, there are parts of medical care that become routinized, just like there are parts of law practice that become routinized. But so much of medical care is so complex. So the Affordable Care Act essentially tries to stimulate some what I would call deeper thinking about quality. One is the Patient-Centered Outcomes Research Institute, PCORI, which is designed to invest in comparative effectiveness studies, looking across a range of conditions and treatments, especially the ones that are high cost and high prevalence, to try and figure out, based on the best evidence, what is the most efficient and most effective way to treat certain kinds of medical conditions. There is another part of the Affordable Care Act that deals with, I think it's been mentioned, the Center for Medicare and Medicaid Innovation, CMMI. CMMI's job really is to test ways of paying for medical care that seem to be correlated more closely with quality. So for example, in a model that I've done some work on, I'm not a CMMI grantee, but I'm familiar with this particular issue. We have far too many babies being born in the United States who are born via C-sections that are scheduled ahead of the due date. And now we understand much more than we did before what kinds of risks those babies face. And so there's been a concerted effort, and interestingly, I mean, I'm familiar with it because Medicaid is now responsible for half the births in the United States. So Medicaid has been a big player in this. There's a concerted effort across all kinds of insurers. They've all come together around this to try and alter the way in which births happen in the United States. Not only because it's better quality of care for the babies, but because in the end it's a more cost-efficient way of dealing with birth when it's not medically indicated to do a cesarean section. So you find sort of these, what Cass Sunstein calls nudges going on, payment nudges, testing nudges, ways to stimulate things like in Medicaid, the growth of health homes, in insurance plans, the growth of medical care homes, medical homes that involve sort of a more robust form of primary care. So much of the quality of medicine, at least that part of it that is dealt with in the law, is absolutely, completely, fundamentally a question of state law. And nothing in the Affordable Care Act changes that. States maintain their primacy in the regulation of medical care. And so what you see instead is the federal government trying to use sort of payment levers, financing levers, experimentation levers to move the quality discussion along.
When I think of the quality components of the Affordable Care Act, I think of the payment reforms, and most of those deal with Medicare, and frankly, most of them are being pursued on a bipartisan basis. They've been bipartisan ideas, and they're going to be codified in this SGR fix. I think they're still exceedingly problematic, and I think they get to the problem of federal control over healthcare. So, for example, the hospital, the penalties for hospital readmissions, I point to that because that's what the administration keeps pointing to, and now there's penalties for having patients readmitted to the hospital, and we've seen a decrease in hospital readmissions, but we've seen a significant increase in a number of patients kept on observation status in the hospital, kept in the hospital for 36 hours but never truly admitted. So they're effectively outpatients, and so they're subject to outpatient copays, which could be exorbitant. So we're basically shifting costs onto the patients, and it creates an interesting tug of war between people like me who are hospitalists who have to manage those patients in the hospital for 36 hours but not go over 2 midnights because then they're at admission, and people like Seth who want to get them out of their emergency room. But this is what's happening, and the issue is that when you try to create these quality measures, when you try to use payment rules to influence medical practice in a very large, vast system where it's hard to measure, hard to exert oversight, hard to get reporting, you get a lot of diversity, you have to create fairly vague rules, but rules that nonetheless where you have an objective measure, where you can measure what the outcome is. And those rules invariably get backed up with civil and sometimes criminal penalties if you don't follow those rules. And they're enforced by basically low-skilled scribes who go into hospitals and do chart reviews and basically look at documentation to try to glean what happened. And I apologize if anyone's a Medicare auditor in this room and I've just called you a low-tech scribe. Unfortunately, this is going to go up on YouTube, and now I'm going to be at risk for the rest of my life. But you get an overreaction in institutions. So the whole emergency room apparatus and the admissions process starts to orient around decisions on observation status and whether or not it's a readmission, and there's a push to get patients onto observation status to lower the rates of readmission. The whole system starts to orient around these rules. If you design perfect rules that are going to lead to perfect outcomes, then maybe you've done something good to improve quality of care. But invariably, when you design these rules in Washington, you're going to get a lot of unintended consequences in a diverse system. And we're seeing that. We're seeing that in the hospitals with something as simple as penalties for hospital readmissions, which at a surface level sounds like a great idea, and it's something that the administration is touting. You're going to start to see in the data adverse outcomes because of what's happening with many of these patients.
I just want to make an observation about this question around quality, and you often will hear the administration sort of tout, well, we've done a lot to try to move the delivery system to a higher quality system and more efficiency, and the hospital readmission policy Scott just talked about, but other, emphasis on bundled payments and accountable care organizations, et cetera. In all honesty, most of that is a total sideshow in the structure of what's really gone on in the law. I mean, they're claiming that that's going to have a big effect, and they're working on a bunch of stuff, and et cetera, et cetera. But the truth is that the law really did what often happens when the federal government is running a health system. It's big savings, it's big downsizing of costs, isn't coming from those kinds of initiatives. It's coming from two things. One is a large across-the-board payment rate reduction for every facility in the country, hospital and otherwise. And it's a permanent, long-term reduction, literally in the trillions of dollars. In the first 10 years, huge amounts of money. And it's likely to lead, the people that run the numbers for Medicare think it's going to lead to a maybe 25% reduction in terms of the hospitals that are willing to admit Medicare patients. This was not a quality initiative, okay? It's where they saved a huge amount of money, but it's done sort of in an across-the-board meat-axe way when they just say, we're going to pay everybody less. They made no distinction among any of the hospitals in the country. They told every hospital, you're all getting less, no matter how well or how badly you're treating your patients. And so that's where they saved money in the bill. So all this talk about accountable care organizations, bundled payments, that is totally minor. That is a sideshow compared to the real budgetary action that's going on in the bill.
I agree that there's certainly a lot of problems with the way that we measure and pay for quality right now. I think the science of quality measurement in healthcare is pretty young and in its infancy right now. Certainly has a lot to grow. I agree. I think the magnitude of the savings we're going to see from quality in the next few years is going to be pretty low. I think we're going to get better at it, and it's going to improve. But Scott says, that the federal government is trying to use payment rules to influence or to change medical care, and that we're going to see a lot of adverse outcomes about this. But we're not instituting this in some sort of, vacuum. For decades, we have been using payment rules to change medical care. We have been paying obstetricians and gynecologists to do C-sections for patients that they probably didn't need. I'm sorry, I know you haven't done it. But we've been paying, the cliches. We've been paying physicians and we've been paying hospitals for volume and not for value. And we end up with all sorts of perverse incentives where look at what was going on in 2010. Could anyone say we had a wonderful, high-quality healthcare system? We clearly didn't. I think it's, we still got our training wheels on, and we're going to stumble a lot before we can run doing this. But sorry, that's a terribly mixed metaphor. But I think the alternative of going back to a simple, straightforward fee-for-service model where all we do is pay for the provision of healthcare services and not at all for making people healthier is just, that's where we were dumping our money for decades.
The problem is that the structure we've set up with the Affordable Care Act is going to be very hard to pay for value because the measurement of value and the prescription of what the appropriate payment rate should be now has to happen in Washington. We've basically federalized that. The insurance companies are no longer taking risks. They no longer have a vested interest in what goes on at the level of care. They're basically contractors for the federal government. And if you look at the health plans, that's why when you look at these health plans, if you go into any state, you look at the silver, bronze, gold, and platinum plan within any insurance company that's offering plans in that state, they're all the same. It's the exact same plan, same exact network. Go online and play around, look at it, see if the doctor network or the drug benefit changes at all. It doesn't. These are basically one-size plans that are prescribed by the government. So now the only way to try to manage quality and influence quality is to do it centrally from a remote agency in Washington. And Medicare has been unable to track quality over the years, and I have no reason to believe it's suddenly going to be able to do that. It hasn't been able to even track patients through an episode of care, which is why we can't pay for episodes of care very often in the outpatient setting, and has not been adept at trying to change payment rules to influence outcomes without creating a lot of unintended consequences. And we've seen it over and over again. We've seen it with the Fistula First program, where they tried to pay surgeons to put in fistulas on patients who required long-term dialysis. That sounded like a great idea, was consistent with the clinical data, but because it was such a blunt rule, it led to all kinds of unintended consequences with patients getting fistulas, native fistulas, who shouldn't have. There were all kinds of reasons why physicians tried to avoid putting fistulas in certain patients. That was very hard for the Medicare program to accommodate with a blunt payment rule. And so we saw bad outcomes. And that's what you're going to see over and over and over again. Because again, medicine's complex, the country is diverse, provider settings are very diverse, the settings in which patients are getting care are very different. And trying to adjudicate rules as if the whole country was a Geisinger clinic, which is the orientation that we often have when we're sitting here in Washington, is folly.
I have to say that I think the one theme that's come out up here on the panel this evening that I have the most trouble wrapping my head around is the notion that the Affordable Care Act is a highly centralized command and control statute. Interestingly, we have a study going on right now for the Commonwealth Fund in which we're looking at plans all over the country. We're doing it systematically. We're reviewing and markets selected to be relatively representative of markets around the country. And there is wild variation, but where the wild variation comes is in deductibles and cost sharing, and in treatment limits and exclusions. Plans are all over the place on their treatment limits and exclusions. I have to tell you that if I stacked up 400 employee benefit plans from around the country, it would be exactly the same story. There would be crazy variation in treatment limits and exclusions, and in cost sharing and deductibles. The plans that you find in the exchange markets today are so much a carbon copy of what any small employer would go and buy, have available to it. The plans were built on this model. The federal government, I mean, the interesting thing is that there was an absolute conflagration at the time that HHS made the decision that it made in 2011 to not regulate the shape of insurance plans. Everybody had assumed that the Secretary of Health and Human Services would come out with exactly a centralized command and control model, very standardized plan, very limited scope of variation, because one of the points of the law was, in fact, to make it a whole lot easier for people to understand their coverage by not having all these crazy bait and switch things that you find in your insurance plans. Instead, HHS bent over, with a lot of help from the White House, bent over in the opposite direction, and essentially has let 1,000 flowers bloom. And from my perspective, of course, the results are very disturbing. That the kind of relative standardization that one might have hoped for, so that you could compare the plans accurately on their networks, for example. Instead, you're swept away by the changes in the deductibles, the changes in the co-payments, the changes in the co-insurance, the fine print on exclusions. I consider it to be actually one of the weaknesses of how the law has been implemented, that we have tolerated and continue to tolerate this much industry control over coverage design. So I think that's an area where you see a really key difference, between people, how people see this law, which is interesting, because if the point of the Rush debates is to find areas of concordance, you could imagine that if we went back and forth long enough, we'd figure out some way to come up with a balanced approach, so that I wouldn't feel as bad about what lower income people are going through in terms of not being able to understand their deductibles, and Scott wouldn't feel as bad about, a too rigid a plan structure. But I think it is really the biggest point that divides us right now up here.
Well, I think if you want to know sort of why people view this as a centralized authority over the system, just look what's happened over the last 6 months. The administration has made a series of announcements about the implementation, mainly on the insurance regulatory side in the last 6 months, that no one knew were coming, and sort of the whole system had to adjust itself around on the fly at the last minute. Think about the issue of, if you like your plan, you can keep it flap, right? That the president essentially announced in November, to try to make that political problem for himself go away, that they would no longer enforce the statutory requirement that these plans were illegal. Now, so the federal government has this authority to essentially rule out of bounds all of these insurance plans, which they had done and led up to that point. Everyone assumed that they were going to be illegal and not be allowed to be offered. And the way they undid it was by saying, the president has just announced, well, I'm going to tell my people in the administration, don't enforce that for the next year. And then he announced later in February that he won't enforce it all the way till October of 2016. The whole system is sort of now had to scramble around and try to figure out what's allowable and not allowable based on that provision. The important point to understand is the federal government has the authority to outlaw all these plans, and now through a whim can unoutlaw them all, at least partially, okay? That's just one example, okay? Think of the Innovation Center. The Innovation Center now has the authority to test things in Medicare and then implement them nationwide if they view the test as saving money in the Medicare program without harming quality. It's a broad, broad authority. Now, that means that everybody is trying to get a grant now from the Innovation Center to test their new idea and their new approach, but it also has essentially frozen in place other private initiatives around innovation and change, because everyone's saying, well, it looks like what's going to happen here is that the federal government's going to test new ideas for how payment models are going to work, and they may mandate within a 3 or 4 year period a nationwide model based on some of those tests. In fact, that's the whole point. And so why go through the process of innovating yourself? Because the federal government is essentially going to test some things and then try to have the whole system come to an accommodation around whatever they think is the best approach to delivery system reform. That's the future. That's sort of where we're headed down the road of, where the federal government really is in charge of a lot of aspects of both the insurance side and the delivery side. And anyone who understands political science and the accretion of power over time knows that federal bureaucracies never give back any power. It never happens. Once they have it, they build upon it because they have a constituency now they're regulating that has to answer to them, and they slowly but surely accumulate more power over that regulated entity. So, I just totally disagree that this is a flexible, we're working with every. The authority is there to essentially run the whole thing from the federal government. And it'll just take a little while to get there.
I'm going to have to call the question.
Okay.
Oh.
I understand. It's 7:55, and we agreed that we would stop here. Maybe we could all come back, and I'd like to thank the panel, if that's okay, for a great job. We would like you to vote, and the way to vote is to put in the colored index card that represents your position: pink in support of the resolution, blue in opposition to the resolution, and yellow for undecided. And we'll see how the vote pre- and post-debate comes out.